Thank you. Can you guys hear me? Okay. My name is Raj Malhotra. I'm an adult cardiologist, but so I don't know any of this stuff, but I am working with Mark and Patty on research related to MSMDS. So thank you for having me. Bernie, I don't know if you remember me. I was a med student when in your rotation in pediatrics, so I still remember you. Just about your last point. So obviously, VQ matching is important in the context of an infection, and that's probably why sildenafil is not helping, right? Because it's vasodilating areas that aren't appropriately getting ventilated. The MGH is involved in the development of a portable nitric oxide generator, and I was wondering if you thought about using that in the acute, like respiratory illness setting for these patients, just to maintain VQ matching, because the inhaled NO will only get to regions of the lung that are ventilated.
There's some irony here, because I actually think we went to the rounds, and I actually took him to see a patient with a patent ductus arteriosus when he was a medical student, which he'll probably remember. There's some irony to that question. The question, it's a really good thought, actually, because you're delivering a vasodilator by the airway. So it's only going to the places, the part of the lungs that's the part of the lungs that are functioning, so allowing the blood. So I think it's a really good idea to give inhaled NO. We have tried it, and every time a few of our friends come in, we do try it. We do try it, but it certainly seems to be the right way to go, rather than systemic. It certainly seems to. We're not sure whether it works, but we'll see. We'll see. But it seems to work better as they get older. The younger ones, I don't know. I don't know. They're a different breed of cat.
I wanted to, now that we're in the Q&A, I wanted to address your question. Can you repeat it for everybody?
I'm Melissa. I'm Joey's mom. So he had surgery. He had a homeograft, and they were originally going to do an artificial graft. Because my concern was, are we going to have to repeat the surgery? Because can the homograft take on the mutation and redilate?
So I'll play the role of Duke Cameron here. So actually, yeah, Duke trained me too. So the quick answer is no. So homograph, for everybody who doesn't know, is where we use a donor aorta, for want of a better word, that's been decellularized and sterilized, and then use it as sort of a aortic transplant into a patient. There are some scenarios in pediatric cardiac surgery where that's preferable to a Dacron tube or an artificial tube. Those are specific circumstances that relate to either the size of the patient, valve dysfunction, or infection, some other specific scenarios. But a homograph won't fail because of the host. So it won't change. It's actually the problem with the homograft is that it's fixed at that size and it won't grow with the child. So it won't fail for that reason.
Hi, I'm Nicholas Hauska. I'm a pediatric cardiac anesthesiologist at Colorado. My question is for either or both of the speakers. For the kids with pulmonary hypertension, do you find that they retain reactivity? And for the parents, I mean, do their blood vessels respond to the normal things that we would expect them to, like oxygen and nitric oxide?
The answer is yes, actually. It seems to be slower. What happens is they go to the cath lab and and don't worry, I have to go over. They go to the cath lab and they've only got partial response to oxygen and you're depressed about it. But they seem to do, it seems to me, slower response than what we're used to than we would see in which call other mutations. but they do seem to retain it, and it seems to be. But you have to persist. You have to persist. I wouldn't. Based on what we're seeing, that there's a tendency to say, take them to the cath lab and see what they respond to. And people are getting away from that. And people are saying, yes, we see responsiveness, which is good, but it doesn't seem to affect our therapy. Because if you look at this, there's a number of triple studies out there at the moment, and those who had poorly responsive, and they found that just persisting with triples over time, they did better than those who just stopped the therapy. So there's a long term. Yeah.
So I'm Patty Mussolino. I'm a stroke and critical care neurologist. So I've been involved in the acute management of several patients, not only at MGH. That stands. So I know, so the big threat here is hypotension. Okay, if you start seeing the blood pressures going down, we can get a hit in other organs, including the brain. So NO is very slow, much less predictable than that you will expect if you have a kid that has hypoxia and you have what it looks like pulmonary hypertension and you give them NO. Definitely not the expected response. We always try it because we don't have that many tools when they are really sick. So, but to have in mind that you may need a vasopressor to be going on at the same time. And one of our intensivists, Dr. Ryan Carroll, always uses the analogy of shunting tetralogy of Fallot physiology. And that's how he thinks through the pressors and stuff. Because at the end of the day, because they don't redistribute blood flow, they end up shunting because they're basically flowing blood to areas that don't have air. So he uses a lot of that to instruct his pressor management, just in case that the frame of thinking helps. But I would always say, try everything that you conventionally will try with something that will keep your blood pressure up, because we don't want the dips on the blood pressure that you can get with those. And Raj, we want your device. When is it going to be ready? The home NO. Okay, amazing.
That'd be great.
Hi, I have a question over here. Cheryl Kerrigan. I am not a doctor, but I am a patient of one of, or several of these wonderful doctors, because I also have an ACTA2 mutation, and I am the voice of everyone online. And Jill from New York has a question for Dr. Lindsay, which is, what is the likelihood of requiring another heart surgery, possibly years later, after the aortic aneurysm repair?
Yeah, it's a great question. We don't know as much about MSMDS in that context, just because the other systems have impacted people's ability to live longer. I think in general, in genetic aortic disease, we've seen that proximal aortic surgery prolongs lifespan by a great deal, but the other parts of the vasculature are still at risk. And so there is a risk later in life, even after a prophylactic, proximal surgery, that, a dissection in the descending aorta or an aneurysm somewhere else in the vasculature is certainly a possibility. I think I can't specifically answer the question for ACTA2 MSMDS, because we just don't have that data in terms of the likelihood. But again, proximal aortic surgery is lifespan extending in genetic aortic disease. It really is.
Do you guys do anything different on an aortic replacement on a kid with narrow vessels in the brain? Is there anything? I know Duke is not here, but good luck, Mark.
I mean, they do selective cerebral perfusion, but they already do that. The children are cooled, and this is typical for pediatric cardiac surgery, that when the heart is stopped, the children are cooled for cerebral protection. There's an infusion of oxygenated blood that's run through the brain, and usually retrograde. And so I think there probably wouldn't be anything special except for, I guess, just we already do cerebral monitoring for oxygen saturation during the surgery, and it would just be continued attend to that actually. And we have a cardiac anesthesiologist if you if you want to help me answer. Please. I haven't been in the OR in a really long time.
So I would say that the things we would do, pretty much what was already said is go colder, do selective cerebral perfusion, definitely do some neurologic monitoring, which is really now the standard of care. But the other thing would be to discuss with your perfusionists and the team taking care of them to make those blood pressure goals a little bit higher than we normally would, and whether that requires running some medications. Maybe because during cardiac surgery, we can be a little bit more liberal with that blood pressure. But in these kids, I communicate to keep that a little bit higher than we normally would.
Thanks. That's a great point. Thank you.
And just voicing my patients that I hear and get on text. Coronary artery disease in MSMDS, ACTA2. What do we know about it? Is there anything in management on kids, teenagers, adults that you guys will recommend to keep an eye on? And what do you do with acute chest pain? So when they start complaining of chest pain.
Wow, that's we do know some things. I mean, I think Dr. Milowitz in her original description of ACTA2 gene changes that cause aortopathy, there was the observation that there's coronary stenosis in some individual patients, out of proportion to what you would expect from just the general atherosclerotic coronary disease that we all get eventually. And that's thought to be similar to the intracranial stenosis in that there's proliferation of smooth muscle cells in the coronary arteries, and in some cases, causing obstruction. The other complexity to that is that smooth muscle process probably also accelerates the typical kind of atherosclerosis. We think, I think some labs have shown that in the mouse model, and I think that makes a lot of sense. We know that smooth muscle instability, promotes atherogenesis. So that's one part of the question. I think we have well-established index for starting a statin medication for atherosclerosis. I don't think we have really, as a community, come down on when a child with ACTA2, MSMDS, or even the other ACTA2 gene changes should be started on a statin, but I would certainly be more aggressive than in an average patient. In terms of chest pain, if you come into the hospital with chest pain, the first thing you're going to do is get a CTA of your aorta, because the primary risk here is aortic tear, mimicking. I mean, that's the primary symptom of a type A aortic dissection is chest pain. So we would get that first, and then we would run down the other causes of chest pain in children. A coronary event causing myocardial infarction in children is super rare, really rare. But with the availability of coronary CTA now, we can, especially in teenage-sized kids, look for coronary obstruction. But again, it's the same algorithm that we would look for coronary obstruction in adults. We look at the EKG, see if there's signs of ischemia. But when you come in with chest pain with MSMDS, we're really going to be thinking about the aorta mostly.
Hi, I have another question from online. This is from Serlin. She says, "Hi, Dr. Lindsay. My daughter is due to have aortic repair. The surgeon also wants to repair branchiolific."
Not sure. Yes, there we go.
I apologize, I butchered that, artery as it's dilated. Are there bigger risks fixing that at the same time? Can this be done separately and not as an open repair?
So I think if you saw in Dr. Cameron's talk, where he showed the different types of grafts and different type of graft surgeries that you could do. He showed one where you just replace the ascending aorta. So that part of the aorta was white. So in some cases where the aortic root is dilated, we replace both the root and the ascending. And then on the far right of that slide was a picture where you replaced the branch arteries, the arteries that are coming out of the top of the aorta that go to your arms and to your brain. And that's the brachiocephalic is one of those. If you're already, the answer to the question is, if you're already going to the operating room for replacement of the aorta and your brachiocephalic is dilated and the surgeon is concerned about it, I would do it at that time. I mean, you're there, you have control, and not wait till that you have to do a separate operation later. I mean, as a pediatric cardiologist, I'd be advocating to the surgeon to go ahead and do that if they saw that region was already at risk.
Great, thank you. And one more came in, Jill from New York. She said, my son has developed paddle PE after his aortic surgery. How long is it recommended to keep him on clot medication, 6 months or for life?
Developed. I didn't understand that question.
You got it. Saddle pulmonary embolism.
Oh, PE.
PE, yeah,
Oh.
saddle PE.
Oh.
We've been in touch, hi Jill, with the cardiovascular team, the pulmonary critical care team of this patient. And just to put it in the map of the disease, we have not seen, and we review also with our hematology team, venous thrombosis in this disease to be increased risk, okay? Venous in the veins. We've seen arterial thrombosis has been published also by Diana Medowick's group and others. When you have a catheter, spontaneous, like the arteries shut down and close down, and when they are narrow, they can get clots. So venous thrombosis is an area that we do not understand whatsoever. So I don't have a specific thing to say about MSMDS and venous thrombosis. And then for a patient that has pulmonary embolization and is an adult and is wheelchair bound, but has never been on Lovenox or any prophylaxis, never had anything. And this was in the context of having to had surgery previously, so post-op. I think I will treat it like I treat all my other adult neurocritical care patients. I would love to hear Nick Mark.
Yeah, I was just make the point that I would treat it like any other PE and not as a special case for MSMDS.
How long is it usually?
I don't treat PEs. As a pediatric cardiologist, fortunately, I very rarely see them. But do you here's the
Usually with a saddle embolism, which causes you significant problems, it's you and you're is it provoked versus unprovoked is what decides how long it is. And now, since there's surgery here, you could say it's provoked, and so that'll more short term. That's the positive news there. Generally, you lean towards long term if it's a saddle embolism, because those tend to be more severe and you don't want them to come back. If so, generally you wouldn't say this case probably not for life, but because it was a saddle embolism and you look at the consequences for the person in front of you, and if it were significant, you'd probably say maybe you should take it for life. So that's what you're balancing every time. If it was a severe event, and you'd say severe event provoked, you'd probably say for life, but you could make an argument for shorter as well.
Great. Looks like that's the end of the.
Any other questions? We're running ahead of schedule by about 15 minutes. So we've caught up. So you have plenty of time. Plenty of time. Drove all the way over here. You might as well get all your questions answered. All right.
For the kids that have. Okay. For the kids that are really involved, like multi-systemic, do you find like using like a Cellucortef or something like that after or during any illnesses help shorten the course? Because I know when it starts to, when you have more brain changes and stuff
So
like that.
generally say we're talking about acute respiratory illness, what happens? So generally what we're doing, and it's anecdotal a bit, so we do tend to put them on antibiotics early, we put them on steroids early, and mainly because we do put everybody on antibiotics and steroids early because there's good theoretical reasons why you would have surfactant effect, why you would be increased with bacterial infections. So we tend to put them on antibiotics early. So when you call now, this year, for example, as all of you have been living through it, is because this year we've had more viral illnesses than we're used to, but clearly the kids with after 2 seem clearly to have more admissions. And it is a standard of quote of our nurses in the PICU. They say, oh, what viral illness have they not got this year? So we've seen multiple admissions this year. So I do clearly. We do give, I really do give everybody inhaled steroids. I've inhaled long-term oral acutely.
So do you notice the difference between using like the Cellucortef versus the prednisolone?
No. And the reasons, and not really, because you're working on them in this case, it's not for asthma, really. You just want to pump up the surfactant promoter so it gives off more surfactant. And that's the reason why we're doing it in many ways. So it doesn't matter which one you give. And the dose really is, we give huge doses, but really and the outpatient, we give just 1 per kilo. That's all we do per day.
Any other questions? One online? Nice.
Hi, this question is from Rachel. Is there a clinical recommendation to cycle antibiotics as pulmonary precaution, specifically erythromycin?
The answer is yes. Well, we don't use erythromycin usually because it's so hard on the stomach, but we use azithromycin 3 times a week. It is standard. I should have said that in my slides. It is standard because it has been shown in other diseases that it decreases inflammation of the airway. But it's particularly true, and say we do it in kids with cystic fibrosis, but we also do it in kids with immune deficiencies. And then there's a couple of other diseases we do as well. It's become standard. There's a very, very rare disease in Japan where it was first described, and what there is an inflammatory lung disease. So that's where it got its start. So we give everybody azithromycin 3 times a week, and it's become standard for us. I think it's particularly true in this mutation because we really do think surfactant is down, and so it becomes standard practice. Yeah.
Working. My name is, there we go. I'm Selena Brown. I'm Journey's grandmother. And I have a question for my daughter-in-law. She didn't want to get up here. But Journey is on, you mentioned albuterol, and she is on, for the nebulizer, they put her on Zopanex. And we live in a small town in the middle of nowhere, so we have to drive everywhere for all these doctors. And so we're just a little concerned about some of the medication and things that she's put on. And this is one of them that they had a question about.
It depends. If you have large airway problems, then which calls Zopanex would be problematic. However, you already know, because if you give it to them and it seem worse to you, you know it's not working for them. So the therapeutic trial is very reasonable. The ipratropium is the thing we talked about. That's older than God. That's in every small town in the world. Literally, it's a very old medication, expensive but old medication. So, but most people end up trialing albuterol or Zopanex, and they end up finding it doesn't work because it relaxes all the smooth muscles. So, as a consequence, we avoid it. Hello? Now you're back. So as a consequence, everyone gets a trial, but usually they fail. And then we just give them ipratropium.
Okay. Thank you.